Okay, well, that was a very nice introduction. I want to lower your expectations, but it's very nice to be with you here. It's a really wonderful, a real pleasure to be joining you here today. When I actually, based on the last panel, we were talking about large-scale change, and there are many different ways of achieving large-scale change through policy. You heard about incentive payments through the insurance system. But one of the biggest drivers of change that we have in our systems right now is technology, the opportunity to actually create large-scale impact through technology solutions that can actually scale change. I want to just start by telling you a little bit about the Institute. You've heard about the Institute for Healthcare Improvement already in the previous panel. We have a mission of improving health and healthcare all over the world. We've worked in 62 countries. Our programs have reached more than 10 million people through our training programs. We have an online quality and safety academy called the Open School that is now in Arabic as well as in English and Spanish and French. Lots of really important results that we've created with our partners, not just in small systems in individual hospitals, but at the level of the whole health system or even in a whole country. So lots of really exciting things that we are working on and doing right now. But I want to start my time with you here today talking about how to scale change by actually talking about two stories of people that are important to me. The first is my sister. This is Gargi. Gargi was born with a blood disorder called thalassemia. Many of you will know thalassemia. It means that the blood cells can't oxygenate very well, and it means that a patient needs to be given a blood transfusion very regularly. In Gargi's almost 4 decades of life, she had many, many doctors in many different cities, in New York, in Boston, in Washington, D.C., in California. And the doctors in the medical system did not talk to each other. They didn't coordinate her care. She fell through the cracks of the system a lot. In 40 years of living with this disease, this chronic disease, the evidence changed, and she had to learn for herself from the research what she should be doing to improve her own care. The doctors rarely communicated to her about the evidence changes. The science as it was evolving, she had to run, in some ways, her own care. When she complained about the lack of coordination and the frustrations, the doctors accused her of being non-compliant and being a problem patient. In the end, at 37 years of age, Gargi died of thalassemia in an ICU in a New York hospital, my sister. And she died not because of thalassemia or the chronic disease, but because of a health system that wasn't coordinated, did not apply the latest and best evidence of care, and did not provide safe, reliable, effective, and evidence-based care at every point in time. This is one type of health system that we have in our world. Here's another patient. This is my mother-in-law, Kamini. Kamini is 74 years old now, and she has multiple chronic diseases, and most importantly, recently she was diagnosed with myelodysplasia, which is essentially a blood cancer. Unlike Gargi, Kamini, my mother-in-law, received care in 3 hospitals separated by 200 miles in Baltimore, in Richmond, Virginia, in New York City. But all of her care was coordinated. The doctors talked to each other, the doctors talked with her. She was involved in every care decision, much like the panel was saying earlier. The evidence evolved in her time. She was started on an experimental therapy for myelodysplasia, and when she was given initially, she was given 18 months to live. She's now still alive 4 years later from her diagnosis because of the kind of care that she has received. Kamini received a very different type of care that mattered to her, care that was evidence-based, care that was coordinated, a system of care that we saw rarely in healthcare today, and a very different system of care than my sister received. These are the two types of health systems that we have today, and what's driving the difference between these two is that in the first example, there was no real system of care, whereas in the second example with my mother-in-law, there is a true care operating system that is taking better care of what matters to my mother-in-law. This is the difference, and I think technology enables this transition from one to the other. So how have we tried to make healthcare better in the past? You heard on the stage some ideas. you heard about standardization. This was the beginning of what we did in quality many, many years ago now. We worked on improving the standard definitions of what it meant to be a hospital or a clinic or a clinical service. In the 50s, we created measurement, quality measurement, and in the 70s, we created what is known as evidence-based care. We rapidly brought research into the healthcare environment, so roughly 50 years ago. Since then, we've been working on ideas like Azar and Soji and others Yasser described on the stage here today, Iman, collaborative quality improvement. All of these are good ideas for how to improve healthcare, but they all suffer from a fundamental problem. And I think that is this. The essence of every one of those three ideas, standardization, evidence-based care, and collaborative quality improvement, is that they are totally dependent on human effort. They rely on people to work harder and to try to work smarter. They are reliant on human effort. We say a lot in clinical quality improvement that we should not be working harder, but in fact we should be working smarter. But I'm going to ask you, how exactly should we work smarter? And I think the essence of this is what I think we need to do next. We need to move from analog clinical quality to what I think of as digital clinical quality. Clinical quality that is not separated from technology. We don't leave the humans and the clinical processes over here and then install the EHR and the technology over here. In fact, we need these two things working together. The people, the technologies, and the processes all working together. We want to make the technology work harder so that our people can work smarter and better. That is the way I think we get to this idea of working smarter, not harder. We do not have a very good track record in healthcare of implementing technologies. In the exhibit halls outside of this room, the many exhibitors will tell you otherwise. They will tell you that their technology is integrated into clinical workflow and that it's easy to use and that it's not challenging, that the clinical life will get much easier. It's only partially true. This is a picture of a clinical encounter between a child and their doctor after the electronic health record went into place. This person on the left side of the slide is the doctor. This person in the middle is the patient, the 10-year-old girl who is getting her care, and then the mother is on the right, and then the waiting room is off to the right as well. Her experience of clinical care was not interacting with a physician in a personal way, but in fact seeing the back of the doctor as he faced the computer. This is the experience of technology in our health system today. We do not build it into workflow. We do not integrate it into the way that we do our work in healthcare, and we need to do better. If we want to have the benefit of all the technology that's in the halls outside of this room, we have to find a way to integrate that technology into the operational clinical workflows of our health systems. And that is the essence of what IHI calls a clinical care operating system. We need to make the tech work harder so that our people can work smarter, and we have to optimize the care system that is capable of delivering the technology to every patient every time. The difference between my sister's care, Gargi's care, is that she never got to experience a hospital and a health system that was driven by a truly optimized care operating system. The difference with my mother-in-law is that she is part of an entire community of health systems that is using technology to drive better care performance for her. So let me tell you a little bit about this idea of clinical operating systems or care operating systems that are technology enabled. IHI, for now, the last 5 or 6 years, has studied health systems that are doing better on clinical excellence. And we wondered, what were these systems doing? Systems like Intermountain Healthcare, Jefferson Healthcare in Philadelphia, lesser known systems like Greater Baltimore Healthcare, like Prisma Health, health systems in Canada like Saskatoon, Singapore Health System. These are systems that are outperforming their neighbors. And we wondered, what was it that they were doing differently? And what we found was that they were putting in place technology-enabled clinical workflows, embedding quality, not into a quality department, but embedding quality and safety and effectiveness into the daily clinical operations of the organization. We've written this up in 2 articles that I placed here on the screen, one in Harvard Business Review, which we published in the summertime, and another in Becker's Healthcare, which we just published about a month ago now. These two articles describe the observations. But let me, for a moment here, tell you about what we found. There are 5 key characteristics of clinical care operating systems that blend technology with clinical workflow. The first is they have co-produced aims with patients, families, and clinicians. So I'll give you an example here of one of these care operating systems. This was a learning health network for epilepsy, for seizure disorder. And when we began this work, the clinicians were deciding what the goal of the learning health system should be. And the goal that they decided was seizure-free days, which seems like a perfectly reasonable idea, right? We don't want our patients to have seizures. But you can achieve seizure-free days. Many of you are clinicians in the room. You can achieve seizure-free days by giving patients very high doses of medications that essentially put them to sleep. Now, patients don't want a seizure-free day if that's the consequence of not being able to live a successful and healthy life. What they wanted was what's here on the bottom, a healthy day without a seizure. And that simple change of the phrase changed the entire aim for the health system that we put together. So the first idea in a care operating system is that we have aims that are centered around what matters to the patients, the families, and the clinical community. It doesn't leave the clinical community out, but it brings the clinical community together with the patients and families to set the goals for the system. The second is the idea of system-wide situational awareness. This is me on rounds at one of the organizations that has a care operating system in place, the Greater Baltimore Medical Center in Baltimore, Maryland. In that system, they have system-wide situational awareness. Every day at 7 a.m., every ward in the entire system meets, and they report on safety risks, on flow risks, on experience risks. So is the patient sitting in bed 7 at risk for an infection? That's a safety risk. Are they at risk for a delay in care? That's a flow risk. Are they at risk to have a bad experience of some kind today in our hospital? It's about what we can do today to mitigate the safety risk, the flow risk, and the experience risk. Anything they cannot solve in that system, they elevate to the divisional leadership. And everything the division can't change, they elevate to the department. Everything the department can't fix, they elevate to the whole hospital. So that 7 a.m. they begin at the wards, 7:15 is the division, 7:30 is the department, 8 o'clock is the whole hospital. And in a single hour, the entire system is aware of every patient in the system that's at risk of a safety or error, is at risk of a flow failure, and is at risk of a bad experience. This kind of enhanced situational awareness, guided by the data in the system, is critical to creating a coordinated and well-organized system of care. The third idea is the central idea of care operating systems, and that is to make the technology work harder. I said it earlier, make the technology work harder so that the people can work smarter. These are the radar dashboards. So we are accustomed in healthcare to moving data up to reporting mechanisms, to higher levels of authority, and then to reporting it out to external regulators and officials. What I'm suggesting we need to do is turn the direction of the data in the other direction. Not only reporting data up, but also reporting data down to the level of the teams. And this idea here is a representative from Jefferson Health in Philadelphia, one of the other care operating systems I mentioned. This is a radar dashboard of Foley lines that are in place today, central lines that are in place today, the risk of infection on the ward today. So here you see they have 8 central lines in their ward right now, one that's at risk and needs to be removed or at least cleaned. So this kind of information in real time is allowing the system to take better care of their patients, not 3 months later, not 6 months later, but today, in real time, in our service unit today. This is an example. This data, by the way, is not sitting in somebody's computer somewhere else. This is where it is. Over here, I don't know if you can see this, but right here, this is the care team at Jefferson, one of the cancer wards. Right here behind them is this dashboard on the screen. So they're looking at this data every minute of every day. Whenever they come back to the nursing station, they see a Foley catheter that needs to be changed, has not yet been changed. And in this way, they bring the data not upwards, but they bring the data back downwards, and they allow the technology to work so that people can take better care of patients. They also collect data in real time. I have nothing against Press Ganey or any of the other patient experience reporting mechanisms, but I'm an internist, I'm a physician. When I get a report from a patient that I saw 6 months ago in the hospital about their experience in care, I don't remember the patient. I don't remember what happened on that day. I don't remember their experience. Anyway, it's anonymized, so I have no idea who it was. This is a reporting mechanism that's happening in real time. This is sitting in the bedside of every patient in Prisma Health in South Carolina. And in this mechanism, they can report in real time that Dr. Mate, I saw him today and he treated me kindly and gently, or Dr. Mate, I saw him today, he was in a hurry, he didn't answer my questions, he didn't seem to care what mattered to me. That information goes directly to me as the physician so that I can adjust my practice in real time, and it gets aggregated and sent to supervisors and to the next level of leadership. Clinicians can also understand the risks of the patient in real time. We have these data. These data are available to us on the phones that are in our pockets, but we don't leverage the phones that are in our pockets to do the hard work that we need to be doing in healthcare. The third one is an obvious one, it's telehealth. Technology here is allowing us to move care closer to home. Much of what's happening with my mother-in-law, Kamini's Health, cancer care, coordinating cancer care across 200 miles in 3 different cities, much of that is happening virtually. She doesn't have to go anywhere. She gets care in her home. She goes to the laboratory down the street to get her bloods drawn. Everything happens very locally for her, and it's much, much easier for someone like her to get the care that she needs. This is a slide actually from Mayo Clinic. Mayo Clinic has developed one of the most sophisticated acute care systems, I would argue, acute care hospitals in the world. We have so many now advanced technologies, point of care testing, point of care medication dispensation, sensors and wearables that allow us to monitor our patients' care. All of that is put together so that we can actually take better care of hospital patients, not in the hospital, but of course in their home and ambulatory care centers. You know this well, but doing this work through a coordinated encounter is now becoming much more possible. Overall, we are moving. This slide I like very much. You can change the company names. It's not important who the companies are on the slide. But the point of this slide is showing you that most of the work that we used to do in the hospital, medical, surgical care, ambulatory care, diagnostic activities, laboratory work, a lot of that work is now shifting into the home and into the community-based setting. Telehealth and primary care is going to be done much, much, much less frequently inside of institutional settings. Even things like ambulatory surgery is going to be done less and less inside of hospitals and health settings. Medical surgical care is moving out of the hospital as well through acute hospital at home. Hospitals in the future will be emergency departments, acute surgical theaters, and they'll be ICUs. And all of the other care that we need in our care settings will move into the home and home-based settings. This is the promise of technology and how we need to make the health technology work harder. When I started, and that's not that long ago, but when I started as a physician, I was treating my diabetic patients this way, asking them to collect data on paper like this about their finger sticks. This is the system we have now. I should even change that first picture. It's no longer a finger stick that you do through a device. It's now in your arm as a continuous glucose monitor, sends the data to a device, it's analyzed, and then there are different care pathways for whether you take care of people inside the app through a portal, or whether you ask people to come in, or whether you do a home care visit. And these are the ways that the future, this is technology-enabled clinical management. And they allow us to work smarter as a clinical workforce. This is an example for Mercy Health in the US. Betty Jo, the chief nursing officer, put in place an AI algorithm to understand the shift schedule for nursing. And this allowed nurses to be matched with shifts that were both important for them developmentally to advance their clinical knowledge, as well as were convenient for their goals. Some of the younger nurses wanted to work very hard and did not want time off. They wanted to work shift after shift after shift. They, of course, managed to put in safety parameters around this, whereas some of the older nurses wanted a very different style of working. They wanted weekends off. They wanted 3-day weekends. So you allow your system to flexibly accommodate your workforce so that they can work smarter. Again, using technology, and in this case, an AI algorithm, to power the system differently. The final thing I will say, the final characteristic of care operating systems that work differently is that they put other care operating systems together into communities of learning. This is all pediatric hospitals in the United States, solutions for patient safety. Many of them have care operating systems themselves, places like Cincinnati Children's Hospital, which we've been working with for a number of years. They link all of those hospital-based technology-enabled clinical operating systems, and they connect with each other and share lessons with each other about how to improve care for kids, for children across the system. A learning system like this has been remarkable at transforming care. It's lowered adverse events. This is a 78% reduction in adverse medication events across not one hospital, but all 144 hospitals, and a lowering of unplanned clinical extubations of almost 50% across all 144 hospitals. Care is safer, it's more effective, and it's scaled, based on the last conversation, to the entire community of children's hospitals. So the care operating system is this. Fundamentally, at its heart, it's those 5 things, but at its core, it allows the technology that we have to enable clinical excellence, to enable clinical workflows so that our people can work smarter and the technology ends up working harder. There are many parts and components of it. I won't belabor this, but IHI has mapped all of this out now. A safety management system, a clinical effectiveness management system, an efficiency management system, a care experience management system. The people are optimized, the workflows are optimized, and the technology is optimized to create the kind of results at scale sustainably going forward. So I will just say in concluding that we need to move from analog clinical quality. We have not taken advantage in health systems today of the true capacity of the technical and technological innovations that we have around us. We have to move from analog clinical quality to true digital quality, and that allows our systems to take advantage of the technologies available to enable better service. We can talk about all the differences in the 2 examples I started with. In the end, care operating systems like these actually allow you to place the patients, which we talked about on the previous panel. What these things allow us to do is the technology enables the clinical workflow so that the patient can emerges and what matters most to them emerges as the key center point of what matters most in the health system going forward. So with that, I'll say thank you very much for your time today, and I hope we'll have a chance to talk more in the future. Thank you.